Um, Imagine, if you will, the legendary detective Medlock Holmes arriving at a grand, highly sophisticated command center. I mean, this command center is responsible for coordinating every single function of an entire sprawling city.
Right, a massive interconnected network.
Exactly. It manages the communication networks, it plots navigation routes, it stores the city's historical archives, and it makes all the critical high-level decisions for every single district.
Yeah.
It is just a marvel of biological engineering.
And it's a beautifully intricate system, provided the infrastructure supporting it is perfectly maintained.
Yeah, precisely. It appears impeccably organized. But one day, suddenly, the operators in this command center begin making strange, sort of uncharacteristic mistakes. Messages to the outer districts are delayed, instructions become completely jumbled.
Highly important historical archives are just, well, misplaced.
Right. Decision-making becomes wildly unreliable. Now, at first glance, the observers, the people watching this happen, assume the command center itself is fundamentally failing. I mean, they think the machinery inside the room is broken.
Which is a very natural assumption to make, isn't it? If the decisions are bad, we tend to blame the decision maker. If the memory is failing, we blame the memory banks.
Yeah, exactly. But Holmes, being Holmes, notices something highly unusual. He realizes the problems are not actually originating from within the command center itself. The internal machinery is structurally sound.
Ah, I see where you're going with this.
Yeah. Instead, the disruptions are arriving from elsewhere in the city. There's a contaminated water supply, or maybe a failing power station in a distant district. Toxic fumes are somehow bypassing the security doors and entering the ventilation system. The communication cables connecting the districts have been damaged by a slow leak.
So the command center isn't broken at all.
No, it is responding almost frantically to problems occurring throughout the wider city.
That is a profound metaphor for what we are exploring today, because in this scenario, the command center represents the human brain. And the wider city represents the entire biological ecosystem of the human body.
Let's unpack this, because we are doing a deep dive today into a specific, utterly fascinating area of medicine and psychiatry. We are looking at cognitive disorders due to another medical condition or substance.
It's such a critical topic.
It really is. We're using Chapter 10.5 of Kaplan Sadok's comprehensive textbook of psychiatry as our structural spine for this conversation. And to really understand the clinical data we're going to discuss, we have to establish a core anchor for how we think about psychiatry.
We do. We need to frame psychiatry not just as the study of mental health in a vacuum, which is how it's often mistakenly viewed, but as the study of how the brain, the mind, and human experience interact, and crucially, how that precise, delicate process can go wrong.
So what does this all mean for our deep dive mission today? It means we are looking at cognitive disorders that do not arise from primary neurodegenerative diseases.
Right. We aren't talking about Alzheimer's disease or Parkinson's disease originating in the brain tissue itself.
No, we are looking at cognitive decline that originates from other medical conditions, from substances, medications, toxins, or systemic illnesses that end up destabilizing brain function.
If we connect this to the bigger picture, a central lesson emerges almost straight away. Human cognition is extraordinarily dependent upon the health of the entire organism.
I think we often forget that.
We do. We often think of the brain as this isolated, privileged unit sitting safely inside the vault of the skull. But it requires a constant, uninterrupted supply of oxygen. It needs precise nutrients to fuel its massive energy demands.
It's an energy hog, essentially.
Oh, absolutely. It relies on hormonal regulation, immune stability, metabolic balance, and continuous communication with the rest of the body. When any of these systemic factors become disrupted, cognitive symptoms, so changes in memory, attention, or executive function, might actually be among the earliest and most prominent signs that something is wrong in the wider city.
If you are listening to this, and you've ever had an elderly relative suddenly become intensely confused or forgetful, your first terrifying thought was probably, oh no, this is dementia.
Which is terrifying, yes.
But what the clinical consensus demands we do is to first look at the city's infrastructure. We have to check if they have a urinary tract infection or failing kidneys, or if their heart medication needs adjusting.
Because if the problem is a contaminated water supply or a failing power station, no amount of tinkering with the command center's internal computers will fix it. Diagnosing someone with a primary neurodegenerative disease when their brain is actually just being starved of oxygen by a failing heart
Or poisoned by a malfunctioning liver.
Exactly. Or that. It's not only incorrect, it entirely misses a potentially reversible, treatable condition. The brain is acting as the messenger, revealing that something else in the body has gone terribly wrong.
It is a vital shift in perspective. You aren't treating a broken mind. You're treating a poisoned or starved organ. So let's dive into the core conceptual framework here. The medical world relies heavily on classification, to ensure we are all speaking the same language. We're operating within the DSM-5-TR nosology of the classification system.
Yes, the DSM-5-TR provides very specific diagnostic categories for this. The primary ones we will dissect are major or mild neurocognitive disorder due to another medical condition, and substance medication-induced major or mild neurocognitive disorder.
Let's focus on those two words for a second, right? Major and mild. Because to a layperson, mild sounds like a minor inconvenience, like a slight headache, and major sounds catastrophic.
It does sound that way, yeah.
But clinically, there's a very specific operationalized difference between the two, and it actually has nothing to do with how bad the memory loss seems on paper. It's about function, right?
It is entirely about function, specifically regarding independence. In a major neurocognitive disorder, there is significant cognitive decline that actively interferes with the person's independence in everyday activities.
And when we say everyday activities, we aren't just talking about remembering a phone number or where you put your keys.
No. We are talking about complex instrumental activities of daily living, what we call IADLs.
Like what, specifically?
Well, IADLs are the complex skills required to live independently in modern society. Can they manage their finances and pay their bills without making catastrophic errors?
Right.
Can they navigate a complex medication schedule, taking the right pills at the right times? Can they safely operate appliances to cook a meal? If they require actual assistance or supervision to do those things because of their cognitive decline, it crosses the threshold into major.
Let me contrast that with mild then. In a mild neurocognitive disorder, there is a modest, measurable decline in cognitive function, but the capacity for independence is preserved.
That is the dividing line. In mild, they can still pay their bills and take their medications, but, and this is the crucial distinction, greater effort, compensatory strategies, or accommodation may be required.
So they might need to hit 3 different phone alarms.
Exactly. Or use a highly detailed color-coded pill box, or spend 3 hours double-checking their bank statements instead of 20 minutes. They are using cognitive workarounds to maintain their independence.
I have to push back a little here, though. Where exactly is the line between just a temporary brain fog like, I had a terrible fever and I couldn't think straight for 2 days, and a true diagnosable neurocognitive disorder due to a medical condition?
That's a very sharp question, and the diagnostic criteria have strict cardinal rules to prevent clinicians from overdiagnosing temporary states. First, the cognitive deficits cannot occur exclusively in the context of a delirium.
We should define delirium clearly because that word gets thrown around casually a lot.
It does. Delirium is an acute, fluctuating state of confusion and altered consciousness. It comes on very quickly, often over hours or days, and a person's attention waxes and wanes. If the cognitive issues, the memory loss, the disorientation, only happen while the patient is actively, acutely delirious, we do not diagnose a separate neurocognitive disorder.
I see.
The same goes for acute substance intoxication or acute withdrawal.
So if someone is acutely intoxicated on alcohol and can't remember the evening, that isn't a substance-induced neurocognitive disorder.
No, that's just intoxication. You have to wait for the dust to settle, wait for the acute delirium or intoxication to clear to see what permanent or long-standing damage remains in the command center.
You cannot assess the structural integrity of a building while the earthquake is still happening.
Precisely. The impairment must persist beyond that acute window. And the second cardinal rule is causality. There must be tangible evidence from the patient's history, their physical examination, or laboratory findings that the cognitive deficit is the direct pathophysiologic consequence of the medical condition or the substance.
It cannot just be a coincidence of timing.
Right. Which brings up a fascinating philosophical point about medical diagnosis. This is described as a diagnosis of inclusion, not a diagnosis of exclusion.
Let's make sure that distinction is crystal clear for anyone navigating this clinically, because I think it gets confused.
It is a vital distinction. A diagnosis of exclusion is what you use when you have ruled out everything else. It's the none of the above category. But what we are discussing today is a diagnosis of inclusion. We do not use this category just because a patient has cognitive decline and we can't figure out what's wrong.
So if we run every test and simply don't know the cause.
We would use a category like unspecified neurocognitive disorder.
You have to have the smoking gun.
Exactly.
Yeah.
To use the diagnosis due to another medical condition, we must have a known identified medical condition, and we must have a known temporal and causative link, showing exactly how that condition is driving the cognitive decline.
It's interesting how different diagnostic manuals approach this, actually. The ICD-11, the International Classification System used globally, handles this by separating known, proven causes from residual categories.
Yes, they list the specific dementias they know about and then group the rest into broad categories like disorders with neurocognitive impairment as a major feature.
Explicitly differentiating them based on whether the exact cause has been definitively identified or remains unspecified.
It forces the clinician to be intellectually honest about what they actually know versus what they are merely observing.
But let's be honest, reality in the clinic is rarely that neat and tidy. You don't just get one physiological problem at a time. What if you're treating an older patient who is in the early stages of Alzheimer's disease and they contract HIV and they happen to have a severe chronic alcohol use disorder?
That happens more often than you'd think.
The city isn't just dealing with a power outage. It's dealing with an earthquake, a structural fire, and a corrupted water supply simultaneously.
This raises the complex issue of how we accurately capture clinical reality without oversimplifying it. The nosology accounts for this with the diagnosis of major or mild neurocognitive disorder due to multiple etiologies.
How does a clinician even begin to untangle that knot?
Meticulously and chronologically. The clinician must establish that the cognitive disorder is the genuine pathophysiologic consequence of more than one distinct etiologic process. And then, from an administrative and coding standpoint, they have to document it properly to reflect that complexity.
So you list everything.
You code all the contributing medical conditions first. You document the Alzheimer's pathology. You document the HIV infection. If there's a severe alcohol use disorder contributing, you code that too. Then you code the neurocognitive disorder due to multiple etiologies.
It's not just bureaucratic paperwork, though. The goal is to capture the true, comprehensive clinical picture, because your treatment plan is going to fail if you only address the HIV but completely ignore the alcohol use.
Precisely. If you only put out the fire but ignore the earthquake damage, the city still collapses.
All right, let's transition from the framework into the actual mechanics. I want to look at exactly how the wider city poisons or destabilizes the command center. Let's start with metabolic and organ dysfunction. When our internal filtration systems break down, what happens to cognition?
Let's examine Wilson disease as a prime, elegant example of a metabolic disruptor. This is an autosomal recessive disorder of copper metabolism.
Okay, let's pause and do a quick translation for anyone who needs a genetics refresher. Autosomal recessive means you have to inherit a mutated silent copy of the gene from both your mother and your father for the disease to actually manifest, right?
Exactly right. It's a mutation in the ATP7B gene. Normally, the body clears excess copper, which we get from our diet, through the liver. The liver packages it into a protein called ceruloplasmin, or excretes it into the bile.
But in Wilson disease?
In Wilson disease, this specific enzymatic transport system is broken. The liver simply cannot excrete the copper.
So the copper just builds up. But how does an excess of a basic mineral lead to a cognitive collapse?
Well, copper is a heavy metal, and free, unbound copper is highly toxic to cells. It generates what are called reactive oxygen species, essentially causing severe oxidative stress and cellular damage. Initially, it destroys the liver, but once the liver is saturated, the toxic free copper spills over into the bloodstream and crosses the blood-brain barrier.
Where does it go once it gets into the brain?
It has a strong affinity for depositing in the basal ganglia. The basal ganglia is a cluster of neurons deep in the brain, primarily responsible for coordinating smooth, purposeful motor movements, but it also has incredibly rich connections to the frontal lobes, which manage cognition and behavior.
Which perfectly explains the clinical triad you see in Wilson disease.
Yeah.
Because the basal ganglia is poisoned by copper, patients frequently present with pronounced motor symptoms, often a severe wing-beating tremor.
Yes.
But because of those frontal lobe connections, they also experience severe neuropsychiatric symptoms, personality changes, depression, even psychosis, alongside progressive cognitive decline.
It is a striking example of how a microscopic enzymatic failure in the liver ultimately dismantles high-level executive function in the brain.
What about larger, more common organ failures, if we look at the kidneys or the endocrine system?
With end-stage renal disease, the kidneys can no longer filter urea and other metabolic toxins from the blood. This is uremia. These toxic metabolites circulate throughout the body, easily cross the blood-brain barrier, and literally bathe the neurons in waste products.
Just marinating in toxins.
Basically, yes. This disrupts the function of neurotransmitter receptors, specifically GABA and NMDA receptors, leading to a profound, sluggish encephalopathy, confusion, and often physical symptoms like myoclonus, which are sudden muscle jerks.
You are literally suffocating the brain in its own metabolic exhaust. And what about the endocrine system? Thyroid issues are incredibly common.
Consider severe hypothyroidism. Thyroid hormones don't just regulate your weight, they essentially set the basal metabolic pace for every single cell in the body, including neurons. Neurons have thyroid hormone receptors. If thyroid hormone levels plummet, the transcription of essential neural proteins slows down. The entire electrical pacing of the brain decelerates.
So the patient experiences sluggish thinking, poor memory, apathy, and depression.
Yes, but the beauty here is reversibility. Restore the thyroid hormone levels with medication, and the cellular machinery speeds back up. The fog lifts.
Which is exactly why a thyroid panel is an absolute mandatory test for anyone presenting with sudden depressive or cognitive symptoms. If a metabolic defect like Wilson's can poison the brain from within, what happens when the brain is starved of a crucial ingredient? Let's talk about nutritional deficits. We have a very specific, historically famous clinical model for this, Wernicke-Korsakoff syndrome.
Yes. Wernicke-Korsakoff is the absolute classic neurological example of how a single missing nutrient can devastate cognition and memory. It is caused by profound neurological damage secondary to a deficiency in vitamin B1, scientifically known as thiamine.
Thiamine. It sounds so benign, like something you just glance past in the multivitamin aisle. Why is thiamine so uniquely critical for brain function?
Because thiamine acts as an essential coenzyme, a biological catalyst for several key enzymes involved in glucose and lipid metabolism. The brain is an absolute energy hog. It represents about 2% of our body weight, but consumes 20% of our glucose.
But the brain cannot extract energy from that glucose without thiamine.
Precisely.
I have an analogy for this that might help visualize it. Think of glucose as the liquid fuel you are pumping into the command center's massive backup generators. But thiamine acts as the specific, precise spark plugs required to actually ignite that fuel inside the engine cylinders.
That's brilliant, yeah.
You can pump all the glucose you want into the bloodstream, but without thiamine acting as the spark plug, the machinery misfires, the cellular engines just shut down, and the neurons run out of ATP, the energy currency of the cell.
That is a highly accurate mechanistic analogy. When those cellular engines shut down from lack of ATP, the neurons literally begin to die. And the clinical data shows exactly where this damage predictably occurs. We see severe atrophy, actual shrinkage, and cell death concentrated in two specific structures, the mammillary bodies and the thalamus.
The mammillary bodies and the thalamus. We need to explain why those two structures are so important, because it dictates exactly how the patient behaves.
These structures are integral components of the PAPES circuit, which is the neural pathway primarily responsible for episodic memory, the ability to record and recall the events of your life.
We usually see this extreme thiamine deficiency in the context of chronic, severe alcohol use disorder, because alcohol actively prevents the gut from absorbing thiamine, right?
Yes, it blocks absorption almost entirely.
But it can happen in any situation causing severe malnutrition, like a patient with Crohn's disease, or someone undergoing prolonged chemotherapy, or even hyperemesis during pregnancy. The initial acute phase of this deficiency is called Wernicke encephalopathy.
Correct. And Wernicke encephalopathy presents with a classic triad of symptoms, though clinically it's important to note that seeing all three simultaneously is actually quite uncommon. The triad involves acute confusion, ataxia, which is a very unsteady, wide-based stumbling gait because the cerebellum is also starved of energy, and ophthalmoplegia.
Ophthalmoplegia meaning paralysis or severe weakness of the eye muscles. The patient literally cannot move their eyes to track your finger. Now here is where the clinical timeline becomes a matter of urgent life or death for the brain.
Yes. If a clinician catches Wernicke encephalopathy in this early acute phase and immediately administers high-dose intravenous thiamine, the condition is potentially entirely reversible. You are rapidly replacing the spark plugs before the engine block cracks. The cellular machinery restarts.
But if you miss that window, if the patient isn't brought to the hospital, or the clinician fails to recognize the triad,
if you miss the window, the lack of energy causes excitotoxicity and permanent cell death. The structural damage to the mammillary bodies and thalamus becomes irreversible. The condition progresses from the acute Wernicke encephalopathy to the chronic permanent state known as Korsakoff syndrome.
And what does a patient with Korsakoff syndrome look like?
It is characterized by a dense, profound anterograde amnesia. The patient completely loses the ability to form any new memories. You can introduce yourself, leave the room for 5 minutes, come back, and they will have absolutely no idea who you are.
That's terrifying.
Oh,
And wonderfully bizarrely, they often exhibit a symptom called confabulation.
confabulation is fascinating.
They aren't lying, right?
No, there is no conscious deception. Their broken memory system simply invents plausible, often highly detailed stories to fill in the gaping holes in their memory. If you ask them what they did yesterday, a patient who has been in the hospital for months might tell you a detailed story about going to the shops and meeting a friend. Their brain is desperately trying to maintain a continuous narrative, and they believe these inventions entirely. Recovery at the Korsakoff stage is exceptionally rare and, at best, incomplete.
It is a devastating reality. A simple vitamin deficiency, if ignored, causes permanent structural brain damage, resulting in complete amnesia. Let's move from missing nutrients to active attacks. I want to talk about inflammatory and infectious intrusions. We've seen what happens when the fuel supply fails. But what happens when the body's own security forces actively turn against the command center?
We see this mechanism very clearly in autoimmune diseases, particularly systemic lupus erythematosus, or SLE. SLE is a systemic disease where the immune system generates antibodies against its own cellular nuclei, causing widespread inflammation.
Now, normally, the brain is protected from systemic inflammation by the blood-brain barrier. I always picture the blood-brain barrier as this incredibly strict, microscopic club bouncer.
I like that.
It stands at the door of the blood vessels in the brain, meticulously checking IDs, letting the oxygen and glucose in, but keeping the systemic immune cells and large inflammatory proteins out.
It's a great visual. But severe chronic systemic inflammation in SLE effectively overwhelms or damages that bouncer. The blood-brain barrier becomes compromised or leaky. Furthermore, the inflammation triggers microglial activation.
Let's define microglia for a second.
Microglia are the resident immune cells, the macrophages of the central nervous system. Under normal conditions, they are the quiet custodians, cleaning up cellular debris. But when they are exposed to systemic inflammatory signals breaching the blood-brain barrier, they become hyperactivated.
So they go from janitors to soldiers.
Exactly. They change shape and begin releasing their own inflammatory cytokines chemical distress signals directly into the neural tissue. This neuroinflammation actively disrupts synaptic communication and causes the severe cognitive dysfunction and brain fog so commonly reported by lupus patients.
And then there's a condition mentioned in the literature that sounds almost like a medical thriller: anti-NMDR encephalitis. We really need to unpack the precise mechanics of this because it is truly mind-blowing and has completely changed how we view sudden onset psychosis.
It is arguably one of the most remarkable and paradigm-shifting discoveries in modern neurology and psychiatry over the last 2 decades. In this condition, the patient's immune system produces autoantibodies, rogue antibodies that mistakenly identify normal human tissue as a foreign invader. Specifically, these autoantibodies cross into the brain and actively target the GLON-N1 subunit of the NMDA receptor.
Okay, we need to slow down and explain what that receptor actually does. Why does attacking the GLON-N1 subunit cause such absolute clinical chaos?
Well, the NMDA receptor is a highly specialized type of glutamate receptor. It is heavily concentrated in areas of the brain like the hippocampus, which is our primary memory processing center. This specific subunit, the GLON-N1 subunit, is absolutely essential for a physiological process called long-term potentiation, or LTP.
And LTP is basically the cellular mechanism of learning, right? Is how synapses strengthen.
Exactly. It is the molecular machinery that allows a short-term, fleeting experience to be physically encoded and converted into a permanent long-term memory.
So if rogue antibodies are physically binding to and disabling that specific receptor subunit,
the machinery of memory formation stops completely, but it doesn't just cause memory loss. Because NMDA receptors are involved in widespread regulatory networks, the patient develops profound cognitive dysfunction and often explosive, severe psychiatric symptoms.
like what?
They can present with acute psychosis, severe agitation, mania, or catatonia. We often see this in young women, sometimes triggered by an underlying ovarian teratoma, a type of tumor that contains neural tissue, which accidentally trains the immune system to attack the brain.
The command center is being actively and systematically sabotaged by its own hypervigilant security forces.
It's terrifying, but again, if correctly identified, it is treatable with aggressive immunotherapy to remove those antibodies.
Now, what about actual foreign invaders, infectious agents? The clinical data mentions everything from neurosyphilis to SARS-CoV-2. How do viruses or bacteria actually bypass that club bouncer and get into the brain to cause cognitive issues?
There are a few distinct anatomical pathways. Some pathogens utilize a process called direct neuroinvasion. They don't bother with the bloodstream. For instance, some viruses can travel retrogradely up the olfactory nerve from the nasal cavity directly into the frontal lobes of the brain, bypassing the blood-brain barrier entirely. Or they might enter via an ocular route following the optic nerve.
They literally climbed through a back door that was left unlocked.
Yes. The other primary route is transmission via hematogenous spread the blood. The pathogen circulates in the bloodstream, generating massive systemic inflammation, and eventually finds a way to penetrate, infect, or damage the endothelial cells that make up the blood-brain barrier, gaining access to the vulnerable neural tissue behind it.
Which we saw with COVID-19, right?
We saw significant lingering cognitive effects with SARS-CoV-2, the COVID brain fog. While the exact mechanisms are still being heavily researched, clinical consensus points strongly toward a combination of direct neuroinvasion, severe blood-brain barrier disruption from a cytokine storm of systemic inflammation, and microvascular damage leading to tiny areas of oxygen deprivation.
It perfectly illustrates how intertwined the city and the command center are. An infection in the lungs sets off an immune response that ultimately degrades memory function. Let's touch on the final mechanical category, structural and perfusion mechanisms. This feels less about biochemistry and more about physics, right? This is plumbing and architecture.
Precisely. It is about the physical environment of the brain. The brain is encased in the skull, which is a rigid, unyielding, bony box. This is governed by the Monroe-Kelly doctrine, which states that the volume inside the skull is fixed.
Right.
If you introduce a space-occupying lesion like a slowly growing brain tumor or a subdural hematoma, which is the collection of blood pooling on the surface of the brain, it takes up physical space that doesn't exist.
And you often see subdural hematomas in the elderly after what seems like a very minor fall, don't you?
Yes. As we age, our brains naturally atrophy slightly, creating more space between the brain and the skull. This stretches the tiny bridging veins that connect the two. A minor bump to the head can tear one of these delicate veins. It bleeds very slowly over weeks or months.
Just a slow drip.
Exactly. As this pool of blood, the hematoma, grows, it physically compresses the underlying neural tissue, distorting the architecture and disrupting function. The cognitive deficits you see will depend entirely on which part of the brain is being swished. If it compresses the frontal lobe, you see apathy and executive dysfunction.
And then there's a structural plumbing issue that often gets misdiagnosed as Alzheimer's. Normal pressure hydrocephalus. You mentioned a classic triad earlier. Let's dig into why that happens.
Normal pressure hydrocephalus, or NPH, involves an abnormal accumulation of cerebrospinal fluid in the brain's internal cavities, called the ventricles. The fluid doesn't drain properly. As the ventricles enlarge like balloons filling with water, they put pressure on the adjacent, surrounding brain tissue.
And the specific structures they compress explain the symptoms.
Exactly. The expanding ventricles specifically stretch and compress the corona radiata. The white matter tracks connecting the frontal lobes down to the motor centers controlling the legs, as well as the pathways controlling bladder inhibition.
Which leads to?
This structural distortion produces the classic clinical triad: cognitive impairment, urinary incontinence, and a very specific type of gait abnormality.
The gait is often described as a magnetic or a praxic gait, right? It looks like their feet are physically glued to the floor. They shuffle rather than lift their legs. If you see an elderly patient with sudden cognitive decline, incontinence, and that shuffling gait, NPH must be at the top of your differential.
Absolutely.
And lastly, in the structural section, perfusion. We touched on this with the heart earlier.
Right. Cerebral hypoperfusion. The brain has no internal stores of oxygen. It relies entirely on a constant second-by-second delivery from the cardiovascular system. If the heart is failing, if the muscular pump is weak, as in congestive heart failure, it simply cannot generate enough pressure to push an adequate volume of oxygenated blood against gravity up to the brain.
So it's essentially a drought in the command center.
The brain is starved of its vital resources, leading to immediate cognitive slowing, confusion, and memory impairment.
Okay, so we have established a thorough understanding of the underlying mechanisms, the metabolic toxins, the missing spark plugs, the immune sabotage, and the physical compression. Now, how does a clinician actually spot these issues in real time? Let's move to clinical manifestations. The literature provides extensive mapping of specific neurological signs to potential underlying medical conditions. It's like a diagnostic cheat sheet for our detective.
It really is.
Let's walk through a few of these because observation is everything. If a patient comes into the clinic with a visible tremor and significant cognitive decline, what is the differential diagnosis running through the clinician's head?
Well, a new onset tremor alongside cognitive changes is a major clinical clue. You immediately think of Parkinson's disease or Lewy body dementia, but based on everything we've discussed, you must broaden the scope. As we explored, Wilson disease must be ruled out, especially in a younger patient presenting with psychiatric symptoms and a tremor.
Right.
And crucially, chronic, severe alcohol abuse can cause both profound cognitive impairment and significant persistent intention tremors. We also have to consider late-stage infectious processes like HIV-associated dementia, which frequently presents with subcortical motor symptoms alongside the cognitive slowing.
What if the clinician during a physical exam notices a gaze palsy? The patient simply cannot move their eyes normally to track a moving pen.
That is a massive red flag, isn't it? A gaze palsy, particularly ophthalmoplegia, where the extraocular muscles are paralyzed or weak, points directly back to a nutritional crisis. It strongly suggests acute thiamine deficiency and Wernicke encephalopathy.
He's part of the triad.
It is a defining feature of that acute triad, and it demands immediate intravenous thiamine before irreversible Korsakoff syndrome sets in.
And what if the patient is confused and exhibits meningeal signs, like severe neck stiffness or pain when attempting to flex their neck to their chest?
Meningeal signs suggest acute physical irritation of the meninges, which are the protective membranes surrounding the brain and spinal cord. In the context of sudden, rapid cognitive changes or delirium, a stiff neck strongly suggests meningitis, an acute bacterial or viral infection of those membranes. That is an absolute medical emergency requiring immediate lumbar puncture and systemic antibiotics.
It's all about looking at the physical, peripheral clues to deduce the internal biochemical stage of the city. Now, I want to pivot the conversation to a different category of disruptors, the foreign agents intentionally introduced to the city, substances and medications. We briefly touched on alcohol's effect on thiamine, but let's look at prescribed and recreational drugs, starting with sedatives, hypnotics, and anxiolytics. We were talking about benzodiazepines, prescription sleeping pills, anti-anxiety medications.
This is an area where the clinical data offers a truly surprising and frankly alarming piece of insight for prescribers. We logically know these drugs cause cognitive impairment while a person is actively taking them. Their entire pharmacological purpose is to sedate the central nervous system by enhancing GABA, the brain's primary inhibitory neurotransmitter. It slows everything down.
Right, that's what they're supposed to do.
But the long-term data reveals that chronic heavy users of these medications demonstrate persistent, measurable impairment in specific cognitive domains, namely verbal memory and processing speed, long after they have completely stopped taking the drug.
We need to define long after. How long are we talking?
The clinical studies highlight that even 6 months after achieving complete abstinence, significant impairments in verbal memory and cognitive processing speed can still be detected on rigorous neuropsychological tests.
6 months. That is profound. That means a patient could stop taking a prescribed sleeping pill or anxiolytic in January, and in June, their ability to rapidly process information or recall a spoken list of words is still demonstrably compromised by that past use.
The neuroadaptation caused by these drugs is deeply entrenched.
That is a massive clinical pearl for anyone evaluating a patient's memory. What about the opposite end of the spectrum? Stimulants. Methamphetamine and cocaine.
Stimulants act like an artificial, overwhelming adrenaline and dopamine surge for the command center. They force the release of massive amounts of neurotransmitters while blocking their reuptake. Over time, chronic abuse of powerful stimulants like methamphetamine severely damages these neurotransmitter systems.
And what does that look like cognitively?
It leads to profound impairment in learning, episodic memory, and particularly executive function. The frontal lobe's ability to plan, organize, regulate emotions, and control impulses.
I have to ask the obvious question. Is that neural damage permanent? Once you burn out the command center's dopamine receptors with meth, can it ever recover?
It's a nuanced and somewhat grim answer. The data notes that for methamphetamine abuse, some degree of structural and functional recovery in these cognitive domains is observed after prolonged abstinence. The brain has plasticity. But prolonged in this context means at least 14 months of absolute sustained sobriety.
That's an incredibly long time to heal.
It is an excruciatingly slow healing process. However, there is a major permanent caveat. Both methamphetamine and cocaine dramatically increase the physiological risk of stroke. They cause severe acute vasoconstriction spasming of the blood vessels and extreme blood pressure spikes.
And a stroke causes permanent, irreversible structural damage to the brain tissue.
Exactly. If the stimulant use triggers an ischemic or hemorrhagic stroke, the cognitive impairment resulting from that specific area of dead brain tissue is permanent, regardless of how long the person stays abstinent afterward.
Let's talk about a class of substances that often gets overlooked. Inhalants, volatile hydrocarbons. We were talking about huffing paint, glue, or historically sniffing leaded gasoline. What is the mechanism of damage here?
The mechanism of inhalant abuse is chemically devastating to the brain's architecture. It causes widespread, diffuse visuospatial and executive impairment. The reason is that these solvents are highly lipophilic, meaning they dissolve in fats.
Okay, so how does that affect the brain?
Well, the brain's white matter is made of myelin sheaths, which are essentially insulating layers of fat wrapped around the nerve fibers to speed up electrical transmission. The inhaled solvents literally dissolve and strip away this lipid-rich myelin sheath, drastically slowing down all neural communication across the brain.
You were literally melting the insulation off the communication cables in the command center.
Yes. And in extreme cases, particularly with historical chronic abuse of leaded gasoline, the toxicity is twofold. You get the solvent damage to the myelin, but you also accumulate heavy metal toxicity, leading to profound lead encephalopathy. This combined assault causes severe, irreversible damage to the cerebellum, permanently destroying the patient's motor coordination and balance alongside their cognition.
Wow. And finally, let's look at a very common, highly effective medical treatment: corticosteroids. Drugs like prednisone or dexamethasone. These are absolute lifesavers for acute inflammation, autoimmune flares, or asthma. But what do they do to the brain when given in high doses?
Corticosteroids have a very specific, targeted adverse effect profile on cognition that clinicians must monitor for. The clinical literature notes that both acute high-dose exposure and chronic steroid use specifically impair two distinct cognitive domains: declarative memory, which is your verbal memory, your conscious ability to recall specific facts and historical events, and working memory, which is your mental scratch pad, your ability to hold and manipulate information in your mind for a few seconds.
Why does a systemic anti-inflammatory drug selectively target those two specific types of memory? Why doesn't it just cause general fog?
Because it comes down to neuroreceptor density. The clinical pattern strongly aligns with the fact that two specific critical brain regions have an incredibly high density of glucocorticoid receptors, making them highly sensitive, almost uniquely vulnerable to the effects of excess circulating steroids.
Which regions?
Those regions are the hippocampus, which manages that declarative episodic memory, and the dorsolateral prefrontal cortex, which is the command center for working memory and complex executive function.
So when a patient is on high-dose prednisone for a lupus flare, and they suddenly seem forgetful, agitated, or unable to hold a complex train of thought, they aren't just stressed about being sick.
Yeah, not at all.
It is a direct, measurable physiological consequence of the medication binding to those specific brain structures and disrupting their function.
Exactly. It is a chemically induced temporary structural impairment.
So we've covered the diverse mechanisms, the biology and physics, and the clinical manifestations. Let's move into integration and clinical reasoning. Let's put on the detective hat. How does a psychiatrist or a physician actually figure this out when a patient walks into the clinic? What is in their diagnostic toolkit?
It begins, as it always must in clinical medicine, with a meticulous, exhaustive patient history and a thorough physical examination. And the clinical consensus emphasizes one point above all others in these cases. Establishing the precise timing of onset is the absolute key to unlocking the correct diagnosis.
Why is timing elevated to such a critical level of importance?
Because you are actively hunting for that temporal causative link. Remember, this is a diagnosis of inclusion. If an elderly patient's cognitive decline began exactly 3 weeks after starting a new high-dose corticosteroid, or precisely 1 month after a severe decompensating heart attack, that chronological timeline is your biggest, most vital clue. You have to establish the sequence of events.
So you're asking questions like,
when did the physical symptoms start? When did the memory issues become apparent to the family? Do the memory issues fluctuate in tandem with the physical illness?
and once you suspect an underlying issue, how do you quantify the cognitive deficit? You don't just ask them if they feel forgetful. You need objective data.
No, self-reporting is highly unreliable in cognitive decline. You use standardized, quantified clinical assessments. The literature highlights several standard validated tools. We routinely use the Montreal Cognitive Assessment, the MoCA, or the Mini Mental State Examination, the MMSE, to get a baseline score for global cognition. We use the clock drawing test specifically to assess visual spatial function and executive planning.
I want to focus on the clock drawing test for a moment because on the surface, it seems almost too simple. You give a patient a blank piece of paper and ask them to draw the face of a clock, put all the numbers in the correct places, and set the hands to a specific time, like 10 past 11. Why is this such a powerful diagnostic tool?
It is powerful precisely because it requires an immense coordinated cognitive load. To draw a clock accurately, the brain has to engage auditory comprehension to understand the instruction, semantic memory to remember what a clock looks like, executive planning to divide a circle into 12 equal spatial quadrants, visual memory to place the numbers correctly, and spatial reconstruction to translate an abstract concept of time 10 past 11 into the physical placement of two differently sized hands.
So it tests the entire frontal parietal network simultaneously.
Exactly. If a patient bunches all the numbers on one side of the circle or can't figure out where the hands go, it immediately indicates severe executive or visual spatial deficits, which might point towards structural issues or specific toxicities.
What else do you use?
We also frequently use the trail-making test Part B. This specifically tests executive function, cognitive flexibility, and processing speed by having the patient draw lines to connect a scattered sequence of dots, alternating between numbers and letters 1 to A, 2 to B, 3 to C. It forces the brain to rapidly switch between two different cognitive sequences.
And then there's the laboratory workup. When you look at the clinical guidelines, there is a massive list of potential blood tests. Complete blood count, electrolytes, fasting glucose, B12, folate, thyroid function panels, RPR for syphilis, HIV screening. But there's a huge flashing warning sign in the psychiatric literature about how to approach this.
Yes. The literature strongly stresses that performing a shotgun approach, ordering all possible tests on all patients presenting with cognitive decline, would be entirely inappropriate, clinically confusing, and a massive waste of medical resources. We don't just order everything and hope a clue accidentally appears on a spreadsheet.
The testing must be targeted.
The testing must be rationally targeted and guided entirely by the findings of the history and the physical exam. If the patient has a history of high-risk sexual behavior, previous intravenous drug use, and a new cognitive decline, you absolutely order the RPR for neurosyphilis and an HIV screen.
Right, that makes sense.
If a younger patient presents with a new tremor, psychiatric symptoms, and subtle liver enzyme abnormalities, you immediately order a ceruloplasmin level to check for Wilson disease. Imaging, like a non-contrast CT or an MRI, is standard to rule out structural issues like silent strokes, tumors, or NPH, but the biochemical blood work must be thoughtful and hypothesis-driven.
Let's bring all this clinical reasoning, this detective work, together with a real clinical case study. This perfectly illustrates the concept of cerebral hypoperfusion we discussed earlier. Let's examine the case of AG. She is a 76-year-old woman with a complex, extensive medical history. She has a laundry list of chronic issues: severe congestive heart failure, hypertension, type 2 diabetes, osteoarthritis, and hypothyroidism. And she keeps repeatedly getting admitted to the emergency department with decompensated heart failure, meaning her lungs are filling with fluid and her blood pressure is dangerously low.
And when the clinicians interview her, what is the stated reason for this repeated life-threatening decompensation?
Well, she admits she stopped taking her prescribed heart medications. She tells the doctors she simply forgets to take them. Crucially, she notes that her memory started noticeably failing about a year ago, which perfectly coincided with her very first hospitalization for severe heart failure.
That chronological timeline is the crucial diagnostic clue. The onset of the cognitive decline perfectly mirrors the onset of the severe cardiac failure.
Right. So during her admission, the psychiatric team tests her cognition. Her MoCA score is 26 out of 30, which is borderline normal. But when they dig deeper, she really struggled with serial sevens, which is the task of counting backward from 100 by sevens.
That specifically tests sustained attention and working memory.
And when they asked her to do the clock drawing, it showed very poor executive planning. The numbers were disorganized. They ordered an MRI, which showed mild chronic small vessel disease common with her hypertension, but no major strokes, no tumors, and no severe cortical atrophy. And her thyroid and other metabolic labs were stable.
So let's break down the clinical reasoning here, because this is where the art of medicine happens. We have a 76-year-old woman presenting with subjective memory issues and objective executive dysfunction. The immediate knee-jerk reaction for many might be to diagnose early Alzheimer's disease and discharge her to a memory clinic.
Right, because of her age.
But the clinical synthesis points in an entirely different direction.
Walk us through that synthesis. Why isn't it Alzheimer's?
First, the temporal onset. The memory issues began abruptly and concurrently with the onset of severe congestive heart failure, rather than the slow, insidious, multi-year progression typical of Alzheimer's.
That's clue number one.
Second, the specific nature of her cognitive deficits. She has poor attention and poor executive planning on the clock draw, which reflects frontal lobe dysfunction, but perhaps not the profound, rapid forgetting of recent events that is the hallmark of early Alzheimer's hippocampal damage.
Okay, and the third?
Third, and most importantly, her physical presentation. She is chronically hypertensive. Her blood pressure is too low. Her failing, weakened heart muscle simply is not pumping enough volume or pressure to push adequate blood up to her brain.
It's a chronic cerebral hypoperfusion.
Precisely. The frontal lobes are highly sensitive to drops in blood flow, which perfectly explains her specific deficits in attention and planning. The final accurate diagnosis was major neurocognitive disorder due to congestive heart failure with cerebral hypoperfusion.
And the true tragedy of this case is the vicious, self-reinforcing cycle it creates. Her failing heart couldn't pump enough blood to her brain. That lack of frontal lobe blood flow caused executive dysfunction and memory issues. Because of those executive memory issues, she forgot to take the complex regimen of medications required to support her heart. Because she didn't take her medications, her heart failure worsened, leading to even less blood flow to the brain, worsening the memory and accelerating the cycle.
It's a devastating physiological feedback loop, and diagnosing her with Alzheimer's would have done absolutely nothing to break that loop.
So, how do we treat it? What is the primary governing principle for treating these types of secondary cognitive disorders?
The primary paramount treatment directive is always to aggressively correct the underlying medical condition or completely remove the offending substance. You do not treat the memory loss directly with dementia drugs. You treat the failing pump.
So you fix the heart?
You optimize her heart failure medication so her cardiac output improves, which restores blood flow to the brain, which improves her memory. If the issue is hypothyroidism, you replace the hormone. If it's Wernicke encephalopathy, you administer high-dose intravenous thiamine immediately. Fix the city's infrastructure, and the command center will often stabilize itself.
Okay, I have a massive clinical pushback here. What if the patient is severely agitated, deeply depressed, or actively psychotic because of this medical condition? Think of the anti-NMDAR encephalitis patient tearing out their 5E lines, or the uremic patient who is combative. Don't we just give them standard psychiatric medications, antipsychotics or heavy sedatives to calm them down or fix their mood while we wait for the antibiotics or steroids to work?
That is a very common, very dangerous temptation in a busy hospital setting, and the clinical consensus explicitly and strongly warns against it. It is referred to as treating by analogy.
Treating by analogy, meaning this patient's behavior looks exactly like schizophrenia, so I will treat it with a schizophrenia drug.
Exactly. Treating a secondary medically induced disorder with a given psychiatric medication simply because the outward symptoms look similar to a primary psychiatric disorder for which that drug was designed. We must be exceptionally, rigorously cautious here.
Why is that?
Because these patients are medically compromised. Their physiology is broken, their livers might be failing, their kidneys might be weak, their blood-brain barrier is leaky.
Which means their pharmacokinetics, how their body absorbs, distributes, metabolizes, and excretes drugs, are completely altered.
Yes. Decreased drug clearance is a massive risk. If you give a standard, healthy adult dose of a powerful antipsychotic to an elderly patient with failing kidneys, they cannot excrete it. The drug will accumulate in their system to toxic, potentially lethal levels.
That's incredibly dangerous.
Furthermore, you introduce a massive risk of severe drug interactions. Psychotropic medications often inhibit or induce cytochrome P4 heavy enzymes in the liver, which can dangerously alter the blood levels of the life-saving medications they are already taking for their primary physical illness.
So you could accidentally stop their heart medication from working just to quiet them down.
Precisely. The guidelines urge clinicians to remain highly skeptical and conservative when using psychopharmacologic interventions off-label for these medically induced conditions. Start at incredibly low doses, monitor obsessively, and be prepared to discontinue them immediately if they are ineffective or cause side effects. We must maintain our focus on treating the root physiological cause, not just chemically suppressing the disruptive symptom.
All right, as we begin to wrap up our extensive deep dive into the complex relationship between the command center and the wider city, let's crystallize the absolute most important clinical takeaways from this material. Takeaway number 1.
Takeaway 1 is the profound concept of reversibility. This is arguably the most hopeful and urgent aspect of this entire field of study. Unlike primary neurodegenerative diseases, which at present are relentlessly progressive and irreversible cognitive impairment resulting from secondary medical conditions or substances, holds the genuine potential for substantial improvement or even complete reversal if the underlying cause is correctly identified and addressed swiftly.
Like the thiamine window.
Exactly. The diagnostic difference between catching Wernicke's encephalopathy in time versus letting it progress to Korsakoff syndrome is literally the difference between full cognitive recovery and permanent, devastating, institutionalizing amnesia. Accuracy is life-saving.
And takeaway number 2.
Takeaway 2 is the paradigm of the interconnected organism. Psychiatric symptoms, including severe cognitive decline and psychosis, may sometimes be entirely indistinguishable from primary psychiatric or neurodegenerative disorders on the surface. A hallucination looks like a hallucination.
Right.
But atypical clinical features, a sudden onset in old age, rapid fluctuation symptoms, a complete lack of family history, or a seemingly unrelated physical symptom like a new tremor or an eye palsy, these must compel the clinician to stop and hunt aggressively for a medical etiology. Cognition does not happen in a neurological vacuum. It requires an integrated, healthy, physiological network to function.
Excellent. Now it is time to transition to our learning reinforcement. We're going to present a rigorous knowledge check for you, the listener. We have 6 single best answer style questions drawn directly from the concepts and mechanisms we've discussed. I will ask the question, we will pause briefly so you can lock in your answer, and then we will provide the correct answer and the strict mechanistic reasoning behind it. Let's go. Question 1. What specific functional criterion distinguishes a major neurocognitive disorder from a mild neurocognitive disorder, according to the DSM-5-TR diagnostic framework?
The answer is interference with independence in everyday activities, specifically regarding complex instrumental activities of daily living, or IADLs. In a major disorder, the severity of the cognitive decline dictates that the patient requires actual assistance or supervision with complex tasks like paying bills, navigating transportation, or managing complex medication regimens. In a mild disorder, the capacity for independence is preserved, although the patient may require significantly greater effort, time, or compensatory strategies to successfully complete those same tasks.
Question 2. Which specific neuroanatomical structures typically demonstrate severe atrophy and cell death on imaging in a patient who has progressed to Wernicke-Korsakoff syndrome?
The answer is the mammillary bodies and the thalamus. Clinical imaging and autopsy data demonstrate that chronic neuronal energy failure, secondary to severe thiamine deficiency, predictably results in the permanent structural atrophy of these 2 critical relay stations within the episodic memory network.
Question 3. In the autoimmune condition known as anti-NMDAR encephalitis, the patient's rogue autoantibodies target a specific receptor subunit that is physiologically essential for long-term potentiation and memory consolidation in the hippocampus. What is the precise name of this subunit?
The answer is the globulin 1 subunit. The profound cognitive dysfunction, memory loss, and severe psychiatric symptoms seen in this encephalitis are directly mediated by autoantibodies physically binding to and attacking the GLUB-N1 subunit of the NMDA receptor, disrupting its essential role in synaptic plasticity.
Question 4. A patient requiring chronic, high-dose corticosteroid therapy develops noticeable cognitive deficits. Based on the specific clinical pattern of impairment, which predominantly affects their declarative or verbal memory and their working memory, which 2 specific brain regions are most sensitive to the neurotoxic effects of excess glucocorticoids?
The answer is the hippocampus and the dorsolateral prefrontal cortex. The high density of glucocorticoid receptors in these areas makes them highly vulnerable to acute and chronic corticosteroid exposure, explaining the specific deficits in episodic recall and executive working memory.
Question 5. A chronic heavy user of prescribed sedative or anxiolytic medications finally achieves complete abstinence. According to long-term clinical data, how long might measurable impairments in their verbal memory and cognitive processing speed persist after discontinuing the drugs?
The answer is, even after 6 months of sustained abstinence. Clinical studies highlight that the profound neuroadaptation caused by chronic GABAergic sedation leads to lingering cognitive deficits that can still be detected on neuropsychological testing half a year after the medication is stopped.
Question 6, our final question. To prevent the overdiagnosis of transient states, what is the fundamental cardinal rule regarding the timing of symptoms required to diagnose a neurocognitive disorder due to a medical condition or substance?
The answer is, the cognitive deficits must not occur exclusively in the context of an acute delirium or in the case of substances during acute intoxication or acute withdrawal. The cognitive impairment must be shown to persist consistently beyond these acute, fluctuating, transient physiological states to be formally diagnosed as a distinct, enduring neurocognitive disorder.
Fantastic. We've mapped the intricate biology of the wider city, we've investigated the vulnerabilities of the command center, and we've explored the myriad fascinating ways they influence each other. But before we conclude this deep dive, I want to leave you with a final provocative thought to ponder as you reflect on this material. Throughout this discussion, we have seen how the filtration capacity of our kidneys, the muscular pumping efficiency of our heart, our daily nutritional intake, and even our past immunological battles with viruses or autoimmune flares physically dictate the fidelity of our memories, our ability to plan our future, and the very nature of our consciousness. If all of these systemic, peripheral, physical factors can so fundamentally alter how we think and who we are, where does the mind actually reside? Is it merely a local product generated solely inside the neural networks of the brain? Or is the true mind actually distributed throughout the entire interconnected biological ecosystem of our body? It is something profound to think about the next time you or a patient experience a bit of unexpected brain fog.
Here are the details of this episode.
Cognitive disorders due to another medical condition or substance. Byline. Sometimes the brain is not the source of the problem. It is the messenger revealing that something else in the body has gone wrong.